Okay, so we'll move right into the discussion. And before we do that, one of the things that we have to reconcile is the fact that the criteria for implementing screening, the barrier that is required for U.S. Preventive Services Task Force, has wisdom and a track record of utility. But we have the situation where we have ongoing screening where the gold standard of mortality reduction benefit has been achieved in the lung cancer space. And we find ourselves as we do this, the centers that are doing this have to deal with the fact that we have this incredible information load that we've been discussing for the last 2 days. And it involves, two of the 4 leading causes of death on the planet. And that information is already available. So asking permission, should I do this screening, is kind of not really relevant. It's done. The question is, are you going to use that data? And we've heard all kinds of things about it. And this is a format in which we're going to kind of continue that discussion and try to come up with a rational, common conceptualization of how we can discuss and articulate where we think we should be going in 2026 in this complicated and exciting new area. John?
Thank you, Jim. We're going to go straight into the discussion. Dr. Kaaks has joined us, yes? Jolly good. Okay, so Jim and I have sort of thought about how to run this session. And what we've actually decided to do was to pose one question, and all of the panel didn't get an awful lot of notice, but they did get some notice. Would they give maybe a 1 minute or 2 minute overview? They can either use slides or just vocally. So the question we've put forward are we ready to begin planning for integrated chest CT scanning in tobacco-exposed cohorts, meaning lung cancer, coronary heart disease, and COPD? And if no, what data do you want to see before moving forward? Now, I don't know how many people have prepared slides? Okay, right. Well, why don't we sort of start the ball with one person that's prepared slides, and then, so Sebastian, do you want to come up and you can have your 1 or 2 minutes, and then the others can go vocally after that, okay? Do you have your slides? Jolly good.
So, it's very, very simple, very short. I will not use all the 28 minutes the clock shows me. So John's question he just framed, yeah, are we ready to begin? And my answer is below. Yeah, so I think if we have an established lung cancer screening program, which is a reminder, not the case in the majority of countries in the world, yeah, I see it as adequate to assess further diseases on the existing CT scans. Yeah, the logic is very simply spoken, if the CT is there anyway, then it gets the maximum out of it. Yeah, this doesn't include a justification to extend the screening and screen people only for coronary calcium or other things that would not qualify for lung cancer screening. Yeah, I think we don't yet have the evidence to do this. Yeah, and a precondition for me are clear guidelines and recommended actions in the CT report. Yeah, and I think this is also a task for the academic community, yeah, to come up with such recommendations, because very simply spoken, don't confuse primary care physicians. They are very busy people, they have a lot to do, they are not deep into the matter, yeah, so it needs to be simple and actionable to make it work. Yeah, and here's a bit the reasoning behind it. Yeah, so I think we should avoid harms of screening. Louis mentioned that we should not have the case where someone comes in healthy and goes out of the screening with 10 different diagnoses, yeah, and we should not extend the population before we have more evidence to do so, yeah, and we should avoid harms to healthcare systems, avoid confusion, avoid too many referrals to doctors who are already very busy, yeah, and 2 recommended readings. One is the ERS, ESTS, and much more guideline on incidental findings. And what I like even more is the paper on the right-hand side from UK, from the Nottingham group, because this is very much like a cooking recipe. Yeah, so how to do this really like take 5 eggs and 200 grams of flour and make it even with examples of letters to primary care physicians and patients. So this is from my side. Thank you.
So we'll keep going. I just do want to comment that we've been using the term incidental findings. At some point, we have to get one of Dr. Jankelowicz's magic questions. Who thinks that's a good term? You're going to tell people they have an incidental finding of proximal calcium on their coronary calcium that was discovered in the context of their screening. I mean, it invites confusion. Oh, it's just an incidental fact that you might have a heart attack in the next 6 months. So we're the group that, is on the tip of the spear. And so simple things like this are the kinds of things that we need to agree. What's the best terminology? What's the best workflows? And this, that, and the other thing. And this discussion is an opportunity to start going on with this. Because the other thing that we should have said more explicitly is, if you don't agree, tell us why and tell us what information you need. If you do agree and you think we should be doing it, what's our next steps?
Okay, let's start. Dr. Kaaks, as you named it, do you want to make a few comments, be it supported, or if no, what else do you actually need to see?
On the question you put up the screen, yeah.
Yes.
I'm not sure fully knowledgeable, to be honest with you, but my general impression is that, of course, lung cancer screening works, and I think that the calcium scoring works very well. And as you just said, Dr. Mulshine, the screening is already there. Are we going to use the information? It seems there's a lot that argues in favor of it. Yeah, the emphysema, as I'm not really a radiologist, I just wondering how specific the measures are and whether a density-based or a Fleshner classification-based kind of diagnosis overlaps and what that actually means in terms of further treatment. But my general comment that I'd like to make perhaps is what are the downstream consequences of giving the information in the targeted population that you have, the actual screening participants, which may be actually quite selected kind of population by nature? What will they do, and to what extent will a risk warning given to them, for example, on the basis of a calcium score, what will that lead to in terms of reclassification of risk, but then also in terms of the corollary, that is, given treatments? What are the risks and benefits of the treatment may they follow, and the costs? Well, from the little I've heard and understand, I think that statins have little risk, and that's one of the most used medications. So I would think that that is then a relatively simple answer. Yet the question will be, how many people were already treated on the basis of other risk factors? What will it do to the specific population that you are actually screening? And is it worth the cost of doing the additional analysis and conveying that information to the people? So that was also a comment made by Dr. Zheng at the end, and I think I concur with that. For the emphysema, I have the impression that this situation is even more difficult. It's not so clear what an early treatment would mean and what it should bring, and let alone how specific the diagnosis itself is, I think. But, yeah.
Okay, Volker, do you want to give your opinion?
Sure, happy to go next. You hear me?
Yes.
Okay. So the short answer to the question is yes. Right? Makes it a little bit simple, and I would put a focus on, yes, we're ready to start planning, because this is an endeavor that needs an awful lot of planning. And I agree, we shouldn't confuse the primary care physicians. I would even go one step further. It's about a year and a half when Wonka looked at this, the World Organization for Family Physicians, and I was in the session, they started with the Menti about how many of the family doctors support lung cancer screening, and that was 60% against. And it was pretty clear saying, what's in for us, except for more work, right? So it's not about just not confusing them, it's you have to bring these people on board, and that starts with planning, with communication. Now, when you go beyond lung cancer, it's not like going from one to the extreme. We've seen this in many settings. In healthcare, it goes one by one. Every disease is a complex world. So pick the first, which obviously is coronary calcium, as the low-hanging fruit. That one we have in the guidelines, we have the technology, good. The other one, keep planning and getting more until you're sure what you implement actually works. It's a deploy to learn phase. And then the data I want to see, absolutely on utility, on health economics, but not in a study that is an artificial setting, actually country by country, understanding what works in which setting and how much do you need to pay, and then you can hopefully get people convinced that they take it over long term.
Okay, thank you. Chris?
To the exact question, anyone who's smoked, should we do screening? I think the answer to that, like the big three, is no, because as we heard earlier today, people with a 0 score on their cardiac, smoking doesn't really matter for them. So I think the way to, but I do think like rebranding as lung health might be a good strategy to go forward. I think at least integrating cardiac screening with lung screening makes a lot of sense. And I agreed with what you were saying about trying to plan right now, because these things take a lot of time to implement. Trying to get the U.S. Preventive Task Force to recognize both lung and cardiac screening as an integrated whole would be beneficial to start working on. And then the other thing I started thinking about is we already have all the NLST data, for example. We know the cardiac and the lung outputs, so maybe trying to reanalyze some of the existing data with an integrated score instead of dividing it arbitrarily, to look at like death as an outcome. I think we could actually get there pretty quickly, for the emphysema, I think is too complicated from what I hear, But I think, going for the low-hanging fruit, which are already here, and also, Croatia, they rebranded it, and I think that might get us out of, the patients not wanting to have lung cancer screening. They probably, if you tell them it's lung health, they'll find that more palatable.
Dr. Zheng, do you just want to pick, you started a comment when you were giving it, but maybe you want to just have an overview.
Yeah, just to tell a little bit about my opinion. So I'm quite conservative, and so if you think reporting some extra funding is risky, then I would say I will not tell patients unless we have some kind of sweet AI companion. They could tell some sweet word to the patients, and they can be acceptable to these words. And I think it's quite important to save these data for the future academic analysis. And although we cannot deal with this data at this time, and I think one of the other keys about integrating this chest CT screening with other diseases is the efficiency. Because we not only increase the communication between the doctors and the patient, we also increase the workload for the radiologist, for example, to report these extra findings. And we really need an efficient AI to help us to, simplify these results. And then I think it's really hard to prepare such efficient AI, because it also will increase the workload of radiologists. They might need to double check the results of AI, whether they are correct, because doctors need to be responsible for the patient at the last, right? So for the other things, I think for integration of this chest CT screening is that we need to prepare a benchmark data set from the multiple centers. And we really need to do that. Although there are many public data sets like PLCO and NLST, they still cannot represent the whole population. We really need to get this kind of benchmark data set, because for this GPT or other Gemini, models, what they do to check their performance, they just collect all kinds of data with different varieties, and they can compare their performance step by step, and they can be more trustworthy. Yeah.
Okay.
Okay.
Comment about that, though. The only problem with what you're saying is, at least in the US, once you introduce an AI tool as part of what you're trying to develop, the regulatory hurdles are rather exceptional. So I'm not sure, because you have to consider all the steps, and I'm afraid that may introduce barriers. And I still agree with what you're saying, is that we have to plan now to, all these things have to happen at the same time. So I think that was a good comment.
But there's a certain amount of reality that we also have to acknowledge, okay? I'm very conservative. And I think in a situation when there's a relative risk of 3, of 3, and the difference between lung cancer mortality and cardiovascular mortality in this cohort,
Right.
the retaining, not sharing that information with the cohort in our country is immoral.
Yeah.
And so I think there's a country by country aspect to it. But we also have to have the screening perspective. If we know these things can happen, what prerogative do we have to withhold this information from the people who are undergoing this stuff while we kind of, dither in doing this, that, and the other thing? And there's been, enormous challenges about this with HIV disease, and even in the early days of lung cancer screening, cohort validation versus randomized control trial. I think we have to be sensitive to that.
Yeah.
And if this stuff is already emerging, I think everybody wants to do it right. But it's kind of interesting to think about what we're talking about. For recommendations, for aging, for just the general population in the US, the recommendation for vaccination, for physical activity, for diet and all that stuff already exists. So the stuff that you might, smoking cessation, the stuff that you might tell somebody who has some, moderate emphysema on a CT scan, the recommendation to do all the things that a pulmonology group using GOLD criteria is going to recommend already exists for the general population over age 65. Yeah. So you're not harming, it's not like you're talking about doing a lung transplant. So I think we have to balance all these things, and we have to think about how to get to a future state where we have this rigorously validated every step along the way. And what do we do today as we're kind of building that bridge? So we're building a road as we walk on it. It's crazy, but that's our challenge. So there's countervening things.
We agree with you in that way, but it's just how to get there. You have to figure out how to get things reimbursed, how to get them translated, right?
And there's one other, Matthias, in terms of CAC information in the Rubinska study, it's already published, right? How did that affect the cost of doing the screening when they had the CAC data and the true information about 0?
Yeah, I think the cost can go down with around 30 to 40%. But you have to calibrate the 0 so that it's safe to do it. So the validation and the calibration of the 0 score I see as the most important step to take. And it can be done, and I think that should be mandatory, that you implement phantom validation for every system worldwide, as presented by Rick Avila. And it can be done with very low costs, but that's probably the only way to get this validation done in a very cost-effective way. And then you can tune down the cost of statin therapy in the United States by 30, 40%.
So you
There's an over-treatment like hell in the United States.
Can you just clarify that one more time? You reduce the statin costs because you could take people off statins that were being overtreated.
Yeah, up to 40%.
So it saved money.
That is what we already know from Rubinska. So
Okay.
the mortality impact also has to come to.
Okay, I am probably the only person here that isn't conservative. Whether it be a small C or a large C. I think we need to be radical. We need to have a 5-year plan, not just sort of we'll wait and see what happens and let's get on with the screening and the other things can fall in place. I actually think we need a 5-year plan. And the second part of the question is, what do we do about it? And I think the thing is we have to be proactive of how we take this forward. Yes, we can go back and look at the NLST. Yes, we can look at the PLCO data, but it's an older data set and how useful it is. I'm sure it's very good from an epidemiological point of view. But actually, what I think we need to do is we need to run these programs concurrent with screening at this moment in time. So they're run in parallel. First of all, maybe observational and then integrated. My greatest concern, and I know it comes from the UK, is the GPs. I have both a daughter and a son-in-law GPs. Ooh, what have you let me in for? So we do have to think about how the GPs and how we actually deal with this. But I do honestly think we do need to have a 5-year plan. We can't just say, well, things aren't in place at the moment and we're not going to do anything about it. I think this is what Agile is about, in my view. We need to be planning of how we actually, the next steps. So I'm going to go through each of the people here because I don't want to just say what happens. I probably will eventually, but can we just start, in your view, what are the 2 things we need to do to get this ball rolling?
Well, right. Just quickly going back to Dr. Mulshine's point, I mean, you described it like almost like an incidental finding one has. One cannot withhold the information. I think that statement is correct, but it's only correct in the context because it's about expected harms and benefit after all, right? So what will it bring to the individual? Little harm probably, because statin is not a very dangerous drug to use and prescribe. It's probably going to be beneficial to the majority of people in the higher risk category. It may be a cost question. And it may also be a question of, in specific populations that you're already screening, who knows by what kind of self-selection these people come. Also, are they already being treated? How much will the scoring actually change to their situation? That kind of question. So I think it will be useful to have descriptive cohorts describing what the impact of such classification is, and also some estimate of what the added cost is to the health system. For bringing people early into this kind of treatment, earlier than they would have otherwise been, perhaps. And ultimately, I think it would be useful to have an idea of how does this have an impact on cardiovascular incidence and mortality, of course.
I agree.
Yeah.
Okay, Sebastian.
I think a simple first step would be to come up with a joint and clear recommendation for prescription of statins. Yeah, so I think we discussed it here, but still even in these rooms, there were varying opinions on threshold. Yeah, is it everybody above 0? Is it everybody above 100? Yeah, so I think this would be a very simple first step. Define the actions. If you find coronary calcium, who gets a statin, who not?
Okay.
Why can't we use existing guidelines?
Okay.
They vary.
The American Heart Association and American College of Cardiology have had a 10-year track record on this.
Yeah.
And I've never heard any disagreement.
But I think one thing you have, I'm clearly not an expert in cardiology, but one thing you always have to check is the prevalence of the population the guideline is aimed for. Yeah, a guideline for the general population may not be applicable to the people you see in lung cancer screening because you have a different prevalence in a different population.
No, they're the same population. They're the same population.
Yeah.
The high-risk group that cardiologist sees is heavily weighted with smokers or former smokers internationally.
Then bring an agile recommendation about prescription of statins from lung screening derived calcium scores.
Okay, let's have Valka's opinion. Let's keep it at 1 because we're running out of time. Just have one main thing that's going to make a difference.
The one main thing, I would say, look at your operational programs that are running now and check your existing UK protocol and adapt it and put it in every of these programs. Start with the standardization of your scans and then put in the coordination of the findings, who reports it, who owns it, who makes sure it's followed up. And if a patient doesn't want it, they can opt out. But don't sit there and make the decision in the white coat that we own the truth. if I have a scan and I get the radiation, I would want to know if I have a COPD or if I don't have a diagnosis, or if I have a coronary calcium. Absolutely. And if the patient isn't asked, and we hopefully have a session there later, we hear that voice. But clearly, the one thing, and this is not one protocol because it's so many countries, but it needs to be a guidance for each of the for the countries to implement something there which works.
Okay.
So this is very heavily, this is anticipated in the rapid learning healthcare system. You've been quoting that kind
Yes,
of.
absolutely.
And that's a systematic approach exactly for this kind of complex problem. And there's already been enormous amount of evaluation and scrutiny of this process. And if we follow that as kind of our logic,
Couldn't agree more. It's 20 years old. You can look it up. It's published. It's an approach that you can just take and apply.
Chris, let's have yours.
I agree with everything, except I still get concerned about the regulatory framework. So if we can gather evidence that U.S. Preventive Task Force will view as key evidence, then I think we're, and in other countries as well. Some countries may be very easy to implement. The U.S. is challenging. So,
Zheng, do you want to give one more?
Yeah, sure. My instinct reaction would be the funding. Although we know the cost for the cardiovascular disease can be reduced, but if we want to integrate emphysema, we really need to figure out how we run the project with the funding, and how can we get the patient get reimbursement. So we need them.
Okay. I got one slide. I decided I'd answer this question as well myself. Can I have my slide? Okay, so I said I'm radical, and I also think we need a 5-year plan. Jim may have seen this slide, and he may or may not agree with me. And I'm actually looking for people to object or to agree or disagree. But actually, some of the comments you will see are actually embedded in this. Okay, lung cancer, we know, is cost-effective, and we have mortality data. That's our starting point. The next is we need to have decent data acquisition and protocol standardization. There were 1 or 2 excellent examples that came from Central Europe. I-ELCAP has one, and Foreign Lung one. But lots of groups don't have good ways of pulling in information. And we need to actually look at how we pull information in and how we integrate our data with primary care. These are things that we need, and pretty well agreeing. We're not ready, but we need to validate coronary vascular disease biomarkers. And I'm using both biological and imaging, and the same goes for COPD. The whole comment about regulatory has been mentioned. We actually can't do anything until we put it, you in the States, or those in the States, FDA, we in Europe, having EU, probably in the UK, we have our own Brexit ideas of how to do things. But the thing is that we do need to bring this to regulation, and we need to prepare it. And are we? Well, we're not. The technical parts, and I'm thinking more of the blood biomarkers, they're great. And there's some great publications coming out. But the problem is the platforms they run on probably cost £150 per patient. Yeah. You might as well go away and do another CT scan. We need to be into £5, £10, euro mark. My view is the big 3 needs to be coming and be prepared. And somebody else said that word, be prepared. CAG and the Robinska study will come out with results, and we're looking forward to that. But my view is we need to implement the coronary artery disease, as in coronary calcium, now. But we need to work with the primary care. And in our own area, in Mulshine, Cheshire, they actually set up a cardiac prevention service where they dealt with things within the screening group, so they actually had less referrals going through and upsetting the GPs. So I think we need to think of how we deal with this and new ways of dealing with it. And then we need to do cost effectiveness. I heard 3 or 4 people mention the word cost effectiveness, because there is no point in actually going through this in the long term for coronary heart disease and for COPD if the whole thing is costing us a fortune and not actually getting us anywhere. And at the end of the day, we need to demonstrate the mortality and the impact. So you can agree or disagree.
Yeah. No, this is kind of a filling out the boxes of a learning healthcare system. This is, you know, however we harmonize on this, we need to do this, okay? The regulatory stuff, the cardiovascular people, I don't think we fully did justice to the depth and richness of the cardiovascular data supporting preventive care in cardiovascular disease. And that already exists. I mean, becoming a participant in lung cancer screening does not vaccinate you against being a member of a species that has cardiovascular disease. When you look at these studies in Scandinavia and stuff like that, cardiovascular findings are present in 90% of the walking, talking population of those countries above a certain age group. And so this is the mandate for countries to take care of cardiovascular disease already exists. There's well-established guidelines for much of this. We don't want to rediscover that wheel. I think we should work with our brethren who have spent the last 25 years sorting this out and kind of benefit from their wisdom. It's not going to add. It's already being paid for. If our recommendations collide on already existing recommendations, there's not going to be new financial assaults. So the cost effectiveness, many of the studies that may be relevant may already be done. And we just have to put them together in a thoughtful way. And what we have to do is get these, what Volker's talking about, if you can take the experience of the institutions that have already done this in a large way and kind of get a sense for the overdiagnosis rates, the fetal thoracotomy rates, the complication rates, those things, and we put those things together, this is going to just move forward. And the U.S. Preventive Services Task Force has never faced an opportunity or challenge like this before. First of all, they don't know if they're going to exist tomorrow, so they're a little bit distracted. But the point is, there's been a mortality reduction benefit demonstrated. That's their gold standard. There's going to be comparable data. That's what the Rubinska is about, and some of the other studies that are coming along are about. Those things are going to emerge. If we do this, if we take an approved process and we engraft it in the screening process, we don't create a new cohort that we have to cross-validate. So I think we have to repurpose a certain amount of stuff in very conservative ways.
Does anybody in the audience want to ask any? Do you want to say something?
David.
Do you have a...
It's a little bit off of the topic you were just talking about, but I wanted to tie it back to the session before where we talked about diagnosis and risk, because in this talk, several of you were presenting these models of risk and comparative models, and I noticed Dr. Zheng, stuck in one of your slides was the word calibration. You didn't talk about it. But, you know, Chris, you showed these different models. You know, your protein marker had a little better than the PLCO marker. You didn't mention what the calibration was. And this is where I think we really run into trouble. This is where these risk markers potentially could really have fallen apart. So I think that this is something that we need to start thinking about. I feel like we're not quite getting the right metrics out there. You know, you can get great ROC or AUCs, but the model can be badly calibrated, and so it becomes, and so anyway, I'm just curious if you wanted to comment on that.
So I think this comes into sharp focus as we emerge into the world of AI.
We need to get this right.
That's the foundational metrology that's going to be used for AI, and if we don't have some agreement about how we go about this measurement science, we will not have AI that will be potentially scalable to support clinical decision-making in this preventive realm. Volker, were you going to say something?
Just one comment, I fully agree, but I absolutely love this diagram with the dynamic going up. The choice of colors is wonderful, because between validate, regulatory, and technology, you don't have a linear process. You have an ongoing circles,
Yes,
and
yes.
that's the learning system. You
Yes.
need the data, then you can show and recalibrate and see what it brings, and then you have the next generation, and it will be the next scanner, it will be the next data set, it will whatever be. This is never going to stop. We will see this emerge based on different technologies, multi-omics, for the next 20 years.
Yes, and to David's point, if you don't have the calibration built in that allows you to see changes, secular changes across time, you're going to chase your tail as opposed to evolve.
One question up here.
I just wanted to bring up again the value of earlier intervention in lung disease, and specifically with COPD. And as to Dr. Mulshine's point, there was a recent New England Journal of Medicine article that showed earlier intervention and treatment with just basic inhalers led to much better outcomes in that population. Even if we can't quantify emphysema, precisely just yet, we could use visual assessment, or we could use a very coarse threshold above 10% or something like that to guide basic interventions with inhalers and, at minimum, smoking cessation.
Yeah, and that was associated with millions of life years gained.
Just one little point. We are using absolute protein levels, and we did recalibrate, but you would have to recalibrate with any kind of test that you do. It's an important ongoing activity. So I agree with what you're saying, but we did do that. But anyway.
So we're in the final 60 seconds. Burning questions, comments.
Question?
Luis.
I brought this up last year. I really think we should think about accreditation. I think that goes along. If you build it, they will come. If you accredit internationally, and we've had some evidence from Iraq that there's all these programs that are starting up, and everybody's doing their own thing, following whoever it is that they learn from. And if we become an association that accredits screening cancer programs, I think we would go a long way to leading the field in terms of saying this is what needs to be done, and this is how it's done properly, and if we audit the way that people are doing it, then we give them an accreditation. And if it's real, everybody else will follow.
Okay.
Good idea.
I think it, Ella, final 15 seconds.
I think my duty as a radiologist,
Workflow.
I think my duty as a radiologist is to the patients, not the payers, not any community, not any clinical guidelines.
Sure.
And when we see emphysema or coronary calcium on a CT, whether it's screening or diagnostic CT done for other reasons, our duty is to the patients, and we should report it. Whether it's quantitatively, as we've been talking about, whether it's descriptively. We've had a nodule detector on our CTs for the last decade. We report none, mild, moderate, severe coronary calcium CT in every CT. It may not be perfect. The enemy of good is perfection. The information is there, and I think we should be reporting this on every chest CT we do, screening or otherwise.
Okay, on that,
Great.
thank you all to the speakers and the panelists.